more skeletal metastases. And as a spine surgeon, this is a hugely important topic for all of us. And there's a lot happening. So she'll introduce the speakers. And we also have herself talk about something that is an every world all-time problem, that's ACLs and all the various age groups. And she's obviously a leading expert in this and has a great deal of practical experience from her own sports medicine background and working, for instance, with the Cleveland Cavaliers, the Cleveland formerly known Indians, and a number of other teams, including, very much to my liking, the San Francisco Golden Gate Rugby Club. And finally, the all-important topic of the next generation and how to educate the next generation properly and what specific problems we're facing is going to be presented by the program director at the University of Washington Department of Orthopedic Surgery and Sports Medicine, Dr. Chris Cowan. And he is phenomenal, great resources, a great addition to the UW, and we're so thrilled to have all three here. Mia, why don't I just pass on to you and you introduce our first speaker. And if you want me to, I can introduce you then for the second part, but we're so thrilled that you put this program together tonight. So good evening, everybody, and thanks, Mia. Take it from here.
Thank you, Dr. Chapman. I'm so thrilled to be here and talking to you all about these important topics, and so happy that my colleagues could join on this. And so Dr. Thompson will be speaking first, and he's one of our musculoskeletal oncologists in our department, and he'll be speaking on 3 critical concepts guiding management of skeletal metastatic disease.
Great. There we go. Slides coming through. Great. Well, Mia, thank you for the introduction. Thank you for the opportunity to speak tonight. As you mentioned, we're going to talk about 3 critical concepts guiding management of skeletal metastatic disease. My name is Matt Thompson. I'm an orthopedic oncologist. I practice at the University of Washington and also the Fred Hutchinson Cancer Center, and also direct the Orthopedic Oncology Fellowship. I have no disclosures relevant to this topic. Jumping right in. When we see a malignant tumor in bone, I was taught and passed along to our trainees that the first 3 things we should think about are metastatic disease. So Mets, myeloma, lymphoma, and everything else. Metastatic disease is extremely common, and in 2020, there are 1.8 million new diagnoses of cancer in the United States. And we know that over half of those tumors will metastasize to bone. And so the orthopedic surgeon is often an integral component, not only of recognition of potentially metastatic cancer, but also the initiation of workup and or palliative care. And what I'll say is, as time goes on, the dogma that surrounded orthopedic oncology and metastatic disease for a long time is changing. It's becoming more nuanced because our medical oncology colleagues are finding new and better ways to treat metastatic cancer and prolong survival. That being said, it's not changing quickly. The median cancer drug development cost is around $650 million, and only about 1 in 10 drugs in general make it from phase 1 to FDA approval. And oncology actually is the lowest of all therapeutic classes at around 5%. And so, for example, immunotherapy drugs, which have been heralded as game changers in many situations, do not work for the majority of patients and may only be effective in about 13% of patients who receive them. And so even though there's reason to be optimistic and there's promise in the future, it remains that the survival when carcinoma becomes metastatic is a poor prognosis and survival is poor. So as orthopedic surgeons, our job is to try to recognize those situations where that's not the case, using the techniques we'll talk about, to identify situations where there may be a projected longer survival and a need for choosing a more durable orthopedic construct to prevent fracture or treat a pathologic fracture. So in that way, a thoughtful orthopedic surgeon can make a major impact on a patient's survivorship by reducing morbidity, preventing suffering, and improving pain, by sparing function, and perhaps most importantly, maintaining or improving independence and quality of life, but also at times recognizing those situations where surgery is not indicated, and we should shift our focus to humane, holistic end-of-life care. And so as I approach these clinical problems on a daily basis, I try to go about it really by thinking about 3 critical concepts. First, I want to understand the patient. I want to understand the disease and the justifications for intervention or non-intervention. I really try to view that through a biopsychosocial frame of reference to try to understand the patient holistically. I think the second critical concept is we need to communicate. We're in an era where we can't stay up to date on all the information. And it's important to communicate with the medical oncologist, especially, to try to reconcile the patient's oncologic and orthopedic goals of care. And then finally, It's hard to talk about metastatic disease in 15 minutes and endow all the surgical principles one needs to be effective in that realm, but we'll talk about some key principles that you can use to approach these clinical problems in general terms. So jumping into the first one, obviously, as with any orthopedic patient, we want to complete history and physical exam, but really focus on the social history. This is where I think we really uncover the most information that's going to help us help our patient make a decision that's right for them at the time. So we're going to talk about their current living situation, their functional level, and their aspirations. What do they want to do, and what kind of support do they have in their home environment to accomplish those goals? And then I think equally important is assessing their level of medical literacy and really bringing that conversation to them while assessing their values, their risk tolerance, and their decision-making paradigm as we present options for treatment or non-treatment. Really, the first step after you've recognized the malignant bone tumor is to form a staging workup. And through this landmark article in 1993 out of Chicago, we know that if we complete standard labs, chest X-ray, CT cap, bone scan, and a biopsy of the most accessible lesion, we're likely to come up with the answer, the primary cancer type. And in the current era, we might add some additional cancer markers to that workup, but in general, that remains the standard workup for metastatic cancer. Once we've completed that staging workup, we need to start thinking about biopsy. And I think the first question we want to ask is, if this does turn out to be a sarcoma, so if we're looking at an isolated tumor that's malignant, if this does turn out to be a sarcoma, am I going to be the one that's going to treat that? And if the answer is no, then the next step is to refer that patient to the center that's going to treat the patient, because biopsy placement is critical so we can manage that at the time of definitive treatment. And when that is not performed, we know that that has a severely negative impact on not only patient survivorship and outcome, but also our ability to perform limb salvage versus amputation. If we're talking about a different circumstance where the disease is metastatic, then we want to try to minimize morbidity by biopsying the most accessible lesion. And if fixation is warranted and you're in a center where you have a capable histologist who can differentiate between carcinoma and sarcoma, then it might be humane to consider doing fixation under a single anesthesia. So do a frozen section and base your decisions on that. But I would express extreme caution in that regard and make sure that your pathologist and yourself are comfortable with that assessment. And if there's ever any doubt about the diagnosis or the additional clinical circumstances affecting that decision, then I would say wait for the definitive biopsy result. As we get deep into this workup about what's causing this patient's presentation, we oftentimes forget about the most important thing. The patient came to us as orthopedic surgeons because they had pain, and that pain could be indicative of a risk of fracture. And so as we're getting wrapped up in this workup to find out what the cause is, we often forget the main thing we need to do at that time, which is to protect their weight bearing and avoid from making the problem worse. How do we assess the risk of impending fracture? Well, we use scoring criteria and our best clinical judgment. I think we're all familiar with Murrell's criteria, so to save time, I won't go into depth into that, but I will say that the limitations for Harrington's or Murrell's criteria are that they do not account for tumor biology, expected responsiveness to treatment, functional status, the patient's comorbidities, or their expected longevity, and in general perform very well in terms of negative predictive value, in other words, identifying those situations where fracture risk is low, but they perform very poorly in terms of positive predictive value. And if you use the Murrell's criteria strictly, there's a potential to treat over 2/3 of your patients. And there are some more exciting technologies coming down the pipeline that we'll hopefully be able to use in the future with better specificity, but they're not widely available just yet. And so in practice, clinically speaking, pragmatically, when we identify functional pain or pain that gets worse with every step, that's considered one of the most specific risk factors for an impending fracture. We want to act on that. Why do we treat fractures prophylactically before they actually break? Well, the answer to that is several-fold. We know that fixation of an impending fracture is more cost-effective, leads to improved function, decreased blood loss and a shorter operative time, but also oftentimes decreased surgical complexity. So a prophylactic rod is much less morbid for the patient to go through than a proximal femur replacement. So catching that bone before it breaks may lead to a less invasive operation. We also know that the ECOG performance score is independently predictive of survival. And so we want to protect that and try to keep these patients mobile and independently functional. And even though this is prone to confounding, there's even some evidence that fixing a fracture prophylactically is associated with a lower mortality than if that fracture actually goes on to break and then is treated. So we evaluated our patient, we understand the risk of fracture and the justifications for treatment if indicated. The next step is to try to understand that particular cancer, because as I mentioned at the very beginning, these cancers are all different. We approach treating them differently. They may respond differently to treatments and have different prognoses. And so that's a lot to keep up on, but I would just recommend finding a resource that you can use for quick reference when you're on call or in the clinic. And this is just a review article that our team wrote a few years ago and published. So we've done our work to understand the disease. Now we're going to move on to communication. And again, most importantly, we want to communicate with the surgical oncologist or the medical oncologist. So we know that surgeons and oncologists alike are bad at predicting survival. Nobody's good at it. It's hard. But having that conversation is important because it helps identify those situations where there might be a reason for optimism, a targetable mutation, some sort of patient characteristic that impacts the medical oncologist's ability to treat that cancer. But we also use additional tools. This is a free service called pathfx.org. It's a free registration. And with that, you can input your patient's specific variables and predict their survival through 2 years post-treatment, which is a helpful tool in deciding how to approach their care. The other thing I always talk to the medical oncologist about, even though it's not a medication I prescribe, is I recommend considering use of a bone-targeted agent like a bisphosphonate because we know that these agents help prevent SREs or skeletally related events, such as fracture or hypercalcemia. And then finally, I want to talk to the medical oncologist about how my modality is going to impact their modality. So if we're planning a surgery, we want to be aware of things like tyrosine kinase inhibitors or any medicine that has an impact on VEGF or affects the ability of a wound to heal, so that we can plan our surgery relative to those treatments or offer the patient a holiday from those treatments to intervene on the fracture. Obviously, we also want to embolize those tumors at high risk of bleeding. And this is just an example on the right of a pathologic fracture due to hepatocellular carcinoma treated with embolization with cement augmented plate fixation using a carbon fiber implant. And then a case of thyroid cancer, the acetabulum treated with embolization, curettage, prophylactic fixation of the posterior column, and then a cemented arthroplasty. Finally, we want to consider radiation. So we've identified those patients who are at risk of mechanical weakening, and we want to treat those patients surgically. But those patients who are having pain and have a low risk of fracture based on our best clinical judgment may benefit from radiation. So we're going to involve that team in our discussion because 90% of patients will report at least partial pain relief, and up to 50 actually report a period of complete pain relief with radiation alone for metastatic disease to bone. We know that single and multiple fracture regimens are equivalent and that retreatment is safe and efficacious if the patient continues to have pain after radiation and remains at a low risk of fracture. So then finally, as I mentioned, we'll try to talk about some very basic principles to use when making decisions about how to approach treating a pathologic fracture. But in general, our surgical construct should allow immediate stability and unrestricted activity. Again, we're trying to protect that ECOG score. We want that patient to function independently. And we also want that construct to outlive the patient's proposed or projected longevity while minimizing morbidity. And I think probably one of the most important aspects of that is recognizing situations where there's a risk that predisposes the patient to reoperation. And renal cell carcinoma is one of the more common ones. So when a patient has a fracture due to renal cell carcinoma, the risk of reoperation is very high. This is just an example of a patient who was treated 2 years prior to presentation at our center with an intramedullary rod for a subtroch femur fracture. That didn't work. The nail failed, and they went on to do exchange nailing and a bone grafting procedure, which also did not result in healing. And so he presented 2 years into this injury, and we treated him with a proximal femur replacement, a segmental reconstruction with a total hip. And in about 3 months, he was back to climbing in and out of boats and working in the shop. And so sometimes doing a little bit more invasive procedure, because we recognize the risk of progression is high, is more palliative and protective of the patient's functional independence. What implant to use? So in general, if we're treating a diaphyseal lesion, we will consider an intramedullary rod as an effective technique for that. That's especially true when we're treating cancers that we predict will have a good response to treatment, such as myeloma, lymphoma. So there's actually a possibility that a fracture could heal in that setting, whereas if we're treating renal cell, we may not use an intramedullary device in the setting of a fracture. The one exception to that is in a patient who's very sick, who has a short life expectancy. Even if they're non-mobile, sometimes a femoral rod can be palliative. And so if they have a short life expectancy, that implant only has to last a short time, we might consider that. We might also when we're treating metaphyseal or periarticular disease, consider rather than using a rod or an implant, using cement and a locking plate and a buttress type of construct to try to protect that joint, that native joint, and avoid the need for an arthroplasty. In general, we include cement when we're dealing with large areas of bony lysis. That's largely because these devices are used as load-sharing devices or designed as load-sharing devices to allow fracture healing. In the setting of a pathologic fracture where tumors replace a significant portion of the bone, they become load-bearing devices long-term and ultimately will fail due to fatigue failure. And so in those situations, we oftentimes will augment with cement for initial stability. That's especially true when we have a low anticipated susceptibility of, that the tumor has a low anticipated susceptibility to treatment, and therefore fracture healing is unlikely. This is just an example of cement augmentation in a patient with a diaphyseal defect treated with a rod. What about segmental resections and reconstructions? These are the situations where really referral to an orthopedic oncologist may be beneficial to the patient just due to frequency of use. We consider these as a single definitive treatment when we see severe destruction, where the bone is so severely biomechanically compromised that we can't accomplish a stable, durable construct with cement augmented hardware. When fracture healing is unlikely again, or in rare circumstances where metastectomy may provide the patient a survival benefit. So renal cell carcinoma is the common one that's tested. But there are other situations where for other types of cancer, metastectomy may actually offer the patient a survival benefit. And for that reason, we might consider a segmental reconstruction. When we're dealing with a patient that's a very high functional demand, we might err a little bit more on the segmental reconstruction side of treatment over fixation procedures. This is just an example of a proximal humerus pathologic fracture due to metastatic breast cancer. You can see on cross-sectional imaging that the bone stock was severely compromised by the tumor. And we didn't think that a locking plate, even augmented with cement, would have adequate purchase to provide that patient long-term stability. So we treated that with a proximal humerus replacement with a reverse total shoulder arthroplasty, which is also a nice palliative operation because after a short period of immobilization, we can allow those patients activity as tolerated. And with good intermediate term survival. What about arthroplasty? When do we talk about doing a joint replacement? Well, when the adjacent joint is at risk or there's pre-existing arthritis, we want to choose that durable operation that's going to last forever. And so in that case, we might resort to doing an arthroplasty. The most common example of this is probably femoral neck disease, where there's a high chance of our rod failing. We don't have good purchase with our other implants. Or there's a risk that if that disease progresses, the joint could collapse. So we'll go ahead with the cemented arthroplasty. In general, I cement the femoral side and press fit the acetabular side when it's possible. And that's because we're going to radiate this bone and it's not going to have potential for on-growth or ingrowth, or it's occupied with tumor. We have to be cognizant of the risk of bone cement implantation syndrome, though, because the risks of that potentially deadly disease are most elevated in patients with pathologic fractures, metastatic disease, lung stem, when we use a lung stem prosthesis and when we pressurize. So we want to be cognizant of that risk and use the long stem only when it's really truly indicated. And then finally, when it comes to periacetabular disease, I think the general wisdom is to try not to operate first. So there are other modalities we can use. And it's especially true in treatable tumors like myeloma or lymphoma, where we're going to protect weight bearing, start systemic therapy, treat the systemic cancer, and then come back in the future if we need to. But with some of these tumors, you actually see the bone remodel with time. You can slowly titrate their activity and avoid surgery altogether. When that's not possible, I think there's a major shift to try to do more percutaneous treatments. And so we'll oftentimes try to perform percutaneous radiofrequency ablation, followed by balloon-assisted osteoplasty, and then cementation with or without prophylactic column screws. So anytime we consent a patient for this procedure, we've just done an anterior and posterior column screw and a corridor screw. We also consent them for this procedure because you're taking that bone and you're injecting cement into diseased porous bone. There's a risk that could extravasate into the joint. So in that case, we convert to a cemented total hip replacement. Sometimes we're not that lucky. Sometimes there's no choice but to go all in on an operation like that. Again, so those are general concepts to consider as you're approaching treatment of metastatic disease. And in the paper I mentioned at the beginning, we went a little bit further and tried to break that down into really 4 contexts. And the dividing line there is we have an impending fracture with limited destruction and potential for healing. We're more likely to choose standard treatment options there. Whereas we move further to the right, where the disease is less responsive, it's a big defect, or the joint is at risk, we may up the ante and do a more augmented reconstruction or segmental reconstruction. And then finally, after surgery, there are things to consider. I mentioned radiation therapy as being critical. And so we generally recommend consideration of radiation therapy in all metastatic patients. Typically, we allow the incisions to heal, but depending on the nature of your reconstruction, that may not be necessary depending on the location of the incisions relative to the radiated field. It's important to remember to prescribe VTE prophylaxis in these patients. Patients with metastatic carcinoma have a significantly elevated risk of blood clots. So we're communicating with the oncologist to choose the most appropriate anticoagulation plan. And then finally, we're dealing with patients who are metabolically challenged. They're going to receive radiation and cytotoxic chemotherapy in a lot of cases. So you want to be really kind to the soft tissues. Use the incision you need to use to do the operation you're performing, and avoid undue trauma to the surrounding soft tissues to promote healing and avoid a complication. So with that, I'll say thank you again for the time. And are we doing questions now?
Yes.
Okay.
Can I ask a question?
Sure.
Well, first of all, Matthew, congratulations. This is amazing what you've packed into this tight 23-minute section, and beautiful images, and some of them are stunning to me as a spine surgeon, the radiolucent implant specifically. Now, here's my question. We just had our 12th annual spine tumor summit at SSF, at over 1,000 people there. One thing that emerged, again, I asked a simple question, I'm going to ask you it also, is who's actually in charge of an oncologic patient? Most of our spine patients come in Thursday nights and Friday nights. I don't know how it is for you. And the surgeons are the only people around. Oncologists usually don't want to until somebody comes back. So who is actually in charge? Do we have to wait until a tumor board assembles a month later, or is it a team sport with a sports medicine heavy theme here tonight? So just elucidate to the decision-making triaging.
I think it's a really good question. And I think in general, a lot of these patients, the orthopedic surgeon can work up and start that process independently. Just depends on their medical acuity and how quickly we're going to talk about initiating treatment. I usually wait till I have actionable information to reach out to my medical oncology colleagues. They appreciate that. But there are times when I also need to consider a multi-specialty approach before that. So I don't think it's an easy question to answer in just a few minutes, but in general, we try to collaborate when we can, but also be cognizant of the times when we need to gather more information really before the other teams can help, and try to manage the patient up to that point.
Well, thank you very much. Really impressive.
Thank you.
Mia, do you want me to introduce you? Do you want to go number 2?
Sure.
So Dr. Hagen is an assistant professor, soon to be advanced, I'm sure, in the Department of Orthopedic Surgery at UW. She's the surgical director of the Sports Medicine Center at Husky Stadium. Phenomenal location, phenomenal place, and she's a team physician for the Huskies, and she's also one of our board meeters in our leadership group. She's academically worked in a wide variety of circumstances, femoral acetabulum impingement and complex knee injuries. She has a bachelor's from Yale, and she did medical school and orthopedic surgery residency at the University of California, San Francisco, and did her sports medicine fellowship at the famous Cleveland Clinic. And as I said earlier, she's worked with the Cleveland pro teams there, including the Cleveland Guardians, then the Indians. And she's really been, in a very short time, a very eminent authority in sports medicine injuries. And all of us who are fathers of young athletes have to realize the ubiquitousness of ACL injuries, especially in young athletes. So I'm really excited that she's taken on the role of just giving us a big picture overview of ACL reconstructions. Thank you, Mia.
Thank you for the introduction. Can you hear me okay?
Yes.
Okay, perfect. I am going to talk about ACL surgery over the next 15 or 20 minutes. And I was thinking of, for a theme, what could I say about ACL surgery that would be interesting to a group of orthopedic surgeons, as this is, one of our most common sports medicine procedures, and so many of you are so familiar with it and experts in it yourselves. So I decided I would just focus on kind of 3 concepts that are sort of hot topics today. And I think what's interesting about each of these is that you'll see our running theme, in which these are all improvements on something that has been done in the past, really. And so we're really revisiting history for each of these, and seeing if they'll work again if they didn't work once before. So just diving right in. So we'll talk about ACL Graph Choice. Obviously, there are several options for auto and allograft. I believe this should be old news to most of you, but the MOON study came out in 2011 in sports health with follow-up data following that, and really showed the two major predictors of graft failure after ACL reconstruction are age and graft type, specifically using an allograft. And so, odds of graft rupture with an allograft reconstruction are found to be 4 times higher than those of an autograft reconstruction. And that really, when you combine that with a young patient age, can be very serious. And so I would say that most of us at this point are using autografts on our younger patients. Besides follow-up studies from MOON, there are multiple other studies from different centers that have really confirmed these data. And so moving on to, the next thought is, what about BTB versus hamstring autograft? And this is a newer study out of MOON that suggests that the BTB might be the go-to graft choice for this young athlete high-risk group. And so they saw that there was a 2 times higher risk of re-tear for the hamstring autograft compared to the patellar tendon autograft. And they actually have a risk calculator that they made based off all of their data in their MOON cohort. You plug, patient hypotheticals in on this website. You can put out the output will show you what the risk of re-tear would be if they were someone with a normal knee laxity versus high-grade knee laxity. This was incorporates the Marks activity score and other things that they found to be significant predictors in their cohort. But the new kid on the block that everyone seems to be talking about today for ACL reconstruction is the quad tendon autograft. This is just some bar charts from PubMed showing the interest in publications on this. And again, these are not necessarily, some of these touch on other concepts besides just the autograft, but you can see really the explosion in quad tendon research that has happened in the last few years alone compared to BTB and hamstring autografts. And if you look at the data of what percentage of ACL reconstructions are quad tendon, it went from 3% in 2010 to 11% in 2014. And now we think it's closer to around 20% of autografts that are going in are quad tendon. So why is everyone diving in here? We know that there are limitations to the BTB autograft in the donor site morbidity, particularly cited as kneeling or anterior knee pain, risks of patellar fracture or tendon rupture, and then also the dreaded graft tunnel mismatch, where your graft might be too long for the tunnels that you drilled, and hence your bone would be sticking out of the tibia. And then the limitations for the hamstring autografts being that potentially greater laxity in that graft, at final follow-up, potential for higher infection rate, and the limitation of the patient's own anatomy in the size or length of their hamstring tendons. And so the quad tendon, it's thought to be a thick, consistent graft diameter that can be obtained with perhaps more favorable tensile properties with load to failure testing. And this is thought to be due to maybe improved collagen or fibroblast density as compared to the other types of autografts. And then potentially a lower risk of donor site morbidity with more remaining tendon available after harvesting the graft. And this has become also very popular in the pediatric population, where people have been seeking a sturdier graft option that doesn't involve bone blocks when you're worried about crossing the physes. What do the data tell us? This is a nice meta-analysis, really compiling a lot of these comparative studies, retrospective and prospective, some case series. And it basically shows that the quad tendon is at least as good as the other autografts based on these data, and potentially that there's less donor site pain. But I would caution, again, I think that we're only starting to really understand the results of quad tendon autograft reconstruction, and it definitely doesn't have as long of a track record in the literature as our patellar tendon and hamstring autografts do. But what's interesting about it is it really isn't a new idea. If you go back to some of the earliest ACL reconstructions in the 1930s, Campbell of the Campbell Clinic was using quad tendon with his, also including a little bit of the patellar tendon in his autograft. And then Marshall also was a big proponent of implementing the quad tendon for the reconstruction using, some of the periosteum of the patella as well. And then, since the 1990s, Fulkerson has been a big proponent of the quad tendon in the US and has been recommending its use. In terms of why the BTB rushed ahead of the quad tendon. I'd be curious to hear the perspective of the audience, or if anyone lived through this and understands it. But as far as I could tell, it seemed like there was just more data coming out and more people just gravitating to the patellar tendon, and because they saw more papers showing good results there, and there wasn't as much published on the quad tendon. And some studies on the quad tendon suggested that potentially there was less quadricep muscle strength postoperatively when people recovered, although that hasn't been borne out as true in the more modern literature. And so I think, again, remains to be seen what the newer outcomes are going to show now that we have better technology of how we're drilling and inserting these grafts. Some cautions with this, though. There still are donor site issues, hematoma being a big one because of the robust blood supply in that area. And then there was a registry study that suggested that the quad tendon revision rate was higher than seen in the other autograft types. This is the only study that I've seen so far that's really shown this. And I do think there's a bit of an asterisk on this data, and that the quad tendon group was really small compared to the other autograft groups. And so it's hard to interpret these registry data, but at least exercise some caution in use of this graft. But certainly becoming more and more popular, and we'll hear a lot more about it, I'm sure, in the years that come. Moving on to the LET, so the lateral extraarticular tenodesis. What is it? So it's taking a strip of the IT band and rerouting it under the LCL and plugging it into the femur. Alternatively, you can also do an actual reconstruction in this area using an allograft. And it's seen as a possible solution to what many of us find after ACL reconstruction, which is that there could be a little bit of residual pivot shift, that we've gotten really good at restoring the Lockman, but the pivot shift remains a little bit of a mystery. Renewed attention to the anterolateral ligament in the last 5 to 10 years has really also helped create a lot of renewed interest in the LET as an option for ACL surgery. There are biomechanical studies that support the function of the ALL, which is really a thickening of the capsule in this area in terms of the rotatory stability and supporting the function of the ACL. What are the outcomes of the LET? If you did your ABOS WLA this year, you might have seen this article, which was a meta-analysis of randomized controlled trials looking at the LET for ACL reconstruction. And what they found is that indeed supplementing the ACL reconstruction with the LET favored decreased positive pivot shift in patients, although no change in the Lockman, as one would expect. And then in terms of graft re-rupture, there was a lower risk of graft re-rupture in the group that would be combined ACL and LET. And they found this to be 3 times less likely. The concept of the LET and the ALL is definitely not new, though. So, looking all the way back into the late 1800s, Paul Sagan wrote about, his famous Sagan lesion, which he talked about before even X-rays were invented. But it's basically that fleck of bone that is the attachment of the ALL to the tibia there. And there were certainly a number of extraarticular reconstructions that were advocated for ACL tears, as in this era of open surgery where people didn't want to enter the joint, as you could lead to things like septic arthritis and arthrofibrosis. Surgeons were looking for other ways to reconstruct and restore the stability of the knee that the torn ACL had provided. And so these were just some examples of extraarticular reconstructions. Probably the most well-known, though, is the lemare technique, which was initially published in the late 1960s. And this is really the modern LET for most people, is just a modification of this, and where instead of taking as long of a strip of IT band as lemare discussed, we take about half that length because we're not doubling it back on top of itself. And then also looking, at Canada, Macintosh also was talking about this lateral substitution reconstruction, which is essentially the same thing, and also had a second procedure called the Macintosh II, where it combined with an intraarticular over the top loop to restore the intraarticular stability as well. And then a whole bunch of other extraarticular reconstructions came out in the same era of people really just looking at different ways to do the same thing. I thought this quote from Dr. Ellison was enlightening, and that and sort of shows the thinking of the time, which is that the ACL is located virtually at the axis or pivot of the knee, and as such, it is at the hub of the wheel. It is easier to control the rotation of a wheel at its rim than at its hub. So why didn't this all catch on right away after this point? There were some studies suggesting that doing an isolated LET on the knee did not restore stability, particularly in your higher grade Lockman, because, and it makes sense when you think about where it is restraining. And there were other papers also showing that the isolated LET did not have offer good stability. And then furthermore, like in the 80s, we had arthroscopy came about, and we got really excited about our ability to do minimally invasive intraarticular procedures. And so the arthroscopic assisted ACL just took over, and as the data showed that it restored the stability of the Lockman very well and very consistently. So these sort of LET extraarticular procedures really faded in favor of the more isolated intraarticular. And now we've just sort of cycled back to the idea again, as we're realizing the limitations of what we're able to do in the joint sometimes. Word of caution on the LET, though, again, is there's this possibility of over constraint. There are a number of recent biomechanical studies that show that this may be creating too much of a restraint on the lateral knee, although the clinical significance of this is yet unknown. So are we creating a possibility for these patients to get earlier onset lateral arthritis? To be determined, but just something to be aware of, and perhaps we'll see more of that in the future. But I think the LET remains a really nice option for patients who may have a higher degree of severity pivot shift or higher risk of graft rupture after ACL reconstruction. So finally, let's touch on ACL repair. So gosh, why are we talking about ACL repair? Well, I think it'll be clear in a moment, but this was one of our earliest ways of trying to treat ACL surgery. And in fact, the first ACL repair was back in 1895, which was like really in the infancies of modern surgery at all, because this is, when all of these more modern concepts of anesthetics and asepsis all came out. This was continued through the 1900s. O'Donoghue, the famous Dr. O'Donoghue, talked about his outcomes with ACL repair, talking about it as being surgically feasible and highly successful if done early. And then Dr. Marshall, also very influential sports medicine surgeon, discussed the good outcomes that he had with ACL repair on his patients. Again, all these were case series, and they were ACL repair, however, came under a fair amount of attack as other studies showed that it wasn't performing as well as other studies, and so, or as the reconstruction. And so this is a study by John Fagan looking at military recruits, showing actually pretty poor results in how they did with ACL repair. And then this study by Lars Engebretsen demonstrated, when comparing the BTB reconstruction to the Kennedy LAD augmentation to the ACL repair, that the ACL repair did really poorly compared to the other two groups. And so this really was sort of like the nail in the coffin for ACL repair. And people really shifted away from this towards more reconstruction after this. If you're wondering what the Kennedy LAD was, it was this polypropylene ligament augmentation device that is also since fallen by the wayside as people have seen problems with this. So why are we talking about ACL repair? It's because there's this new device out called the Bear implant, which you may have heard of, bridge enhanced ACL restoration. And the idea is, in addition to sewing the ACL back together, now we put a piece of PRP soaked sponge basically around it. It's something to induce the healing response of that ligament. And so if you go to their website, you can look at the technique of how they recommend to do it and all of the great things they say it does. There is a recent trial. So the reason it's approved now is because this trial came out showing that, at least for a non-inferiority study, it performed about the same as BTB reconstruction. However, it was powered for IKDC. And one thing that I would note of caution, I note, is in the results, they report 14% re-injury in their Bear group versus 6% in the ACL group. And so although this wasn't statistically significant, that might have been a result of being underpowered. So phase 3 trials are currently underway, one within Moon and one outside of Moon. And so I'm sure we are going to hear a lot more about the Bear in the years to come. But interesting that we are, again, revisiting an older concept. So in conclusion, I think, the modern techniques and trends and hot topics in ACL surgery all have these interesting foundations in history. And time will really tell how these new techniques hold up in terms of using the quad tendon as a graft, LAT, and the bridge enhanced ACL restoration. Thank you very much.
Well, yeah, this was fantastic. Again, just like Matthew before, an incredible journey through ACL reconstruction from past to present and even future, with a tremendous scope of intra and extra-articular options. My question to you is, as you're facing an athlete, aside from age, how do patient factors in sports weigh into your decision? Specifically, let's say somebody who is in a final contract and needs to get out in the field as soon as possible. So a linebacker does not need to cut and twist too much. Does that change your angle? Would you even consider an allograft, a really beefy allograft in that? And again, then look at that, compare that with a young female athlete who twisted her knee. She has a tight femoral notch. I'm not sure whether that matters still. And she has a collegiate career, but she has maybe a year to give. So position and sports-specific, body physiology-specific factors. How much is that risk score a factor? How much is just your intuition or the patient preference of getting back on the field versus I'm going to rehab this out a factor?
Yeah, that's a great question. When we look at the young athlete, I think most people would agree that surgery is recommended at this point in order to given the highest likelihood of returning to sport, although we know it's not 100%. And a lot of times there's factors outside of just the success of the surgery that go into that. In terms of specifics of the sport and what graft to use, my personal philosophy is that I gravitate towards the BTV. That's my kind of go-to for the athlete group in general, with very minor nuances potentially. Like if I'm concerned about kneeling pain or impact of the patella on the ground as being something that may bother them, I may just discuss that and talk about, the quad or, the hamstring as other options. But I'm almost never putting in allografts in athletes anymore. I just am a firm believer in that Moon study and the data that they presented there. But I know that other people have different philosophies on it. And like I said, the quad tendon has recently shown a really nice track record. And so a lot of people are gravitating towards that for their athletes as well.
A great answer. One final quick question, and that is, proprioception seems to be such a big deal. Is that eternally lost after an ACL tear, regardless of your reconstruction technique, or can you train that back on again?
A big part of the recovery after ACL surgery is how can we retrain the knee and prevent re-injury. And you're right. I think that it is tricky, but we certainly get people back to pretty close to normal activity levels. And if you look at, again, the follow-up data, even at 10 years. And so it involves a lot of patient dedication to their physical therapy and to their retraining of their mechanics. But there is, and this is why, again, we're visiting things like the LET, because there's something about the kinematics of the knee that does change after ACL reconstruction. We haven't gotten it totally right yet. And so, again, we're striving for getting them exactly the way they were before they were injured. And it's hard.
Really cool perspectives. And thank you for doing that. We'll use that as a resource for ACL decision-making. Would you be willing to introduce your program director next, who you got to discuss the intricacies and new insights in resident education?
Sure. So I'm so excited to introduce our next speaker, Dr. Kwan. He is just down the hall from me right now in our Husky Stadium clinic, and he's our program director for our residency. And he's been doing a fabulous job helping educate the new wave of residents here. And so I'm excited to hear him speak on teaching orthopedics to a new generation, the perspectives of a Gen X program director. So thank you very much, Chris.
Okay, thanks so much, Dr. Hagan, Dr. Chapman. Big shoes to follow after these great talks. I'll kind of finish off these last 15 minutes talking about just things that I've learned and maybe a thought process that I have in my role as program director. I took over for Dr. Doug Hannell July of 2019 and immediately tried to oversee a residency program with COVID and aspergillus and everything else that's been happening. But I think I've learned quite a bit just from gleaning from my direct experience and learning from great partners like Dr. Hagen and others here at the University of Washington. So thanks for having me. No relevant disclosures. I am still actively learning how to teach orthopedic surgery while simultaneously trying to figure out how to do orthopedic surgery well. So just that as my main disclaimer. Just like any other good talk, we'll kind of hit a couple of points over the next 15 minutes. And just starting out with just these generations defined. In general, generations can be defined by the age or how old you might be as an indication of what generation you fit in. In general, we think of the baby boomers being in their mid 50s to mid 70s, Gen X, the next generation, being somewhere in the early 40s to mid 50s. The generation below that, the Millennials, which this talk is really going to focus on, also known as Gen Y, being in their mid 20s to early 40s. And then Gen Z, at this moment in time, being the current or kind of youngest generation. But I think more helpful than age, I think understanding or thinking about generations in relation to that group of people's shaping events, I think is a little easier. So the boomers, classically, we think of them as being a part of this post-World War II optimism and growth, especially here in the United States, the Cold War, hippie movement. Generation X, this latchkey generation, a small generation sandwiched in between two large or our largest generations, the boomers and the millennials. And I think that the key shaping event of Generation X is this transition into what is now our current technology. So Generation X, if you remember what life was like with a dial-up phone, quarters in the payphone that you had to find, 386 computers, if that really rings true, like in terms of your memory, then you are probably Generation X. And that is differentiated with millennials, which they're kind of defined as the generation who clearly remembers 9/11, lived through the Great Recession in that early mid 2000s, but more important than that, born with the current iteration of technology and probably more importantly, social media. So like they don't remember having no smartphones or no internet or no email. That's not a memory that they clearly have. They only remember what we have now. And then Generation Z, we don't know yet, honestly. It's like how they're going to be defined is basically determined by what's happening now or in recent memory. So it might be the war in Ukraine, it might be this upcoming recession, who knows. In orthopedic surgery, our current workforce in ortho are made up of boomers. They're the professors. They're retired, approaching retirement, kind of on the back half of their career. Generation X is truly a mix of junior, mid, and senior faculty. And the millennials are basically our trainees. They do make up some of our junior faculty, but essentially they are our current trainees. And the next generation up are either in medical school or in college and soon to be our next group of learners that we're going to have to understand and help with. So this talk is really focused on millennials primarily, because that's who makes up our current trainee workforce. And so just in general, conceptually, I think you can make some arguments that some of the strengths of today's youth or the millennial generation is that they're smarter. I think that like finding answers and content is not an issue for them. So think back at your days in college, in med school, that if you had to find the answer to something, you had to go to the library, you had to find the textbook, you had to figure out what to do to just get the answer, to just know what it is you had to do or understand. And now you literally can just type in something and figure out the answer instantaneously without having to go look it up or physically go somewhere. I've had med students that almost verbalize the steps of a surgery that they're in with me because they watched a number of videos, either created by myself or one of my partners or on a website, and they literally almost can just mimic what to do for an ACL surgery, for example. Multitasking has never been easier. I think that doing multiple things at the same time is something that I think the younger generation has become accustomed to, juggling things. I think before our current iteration of technology, you just kind of had to do one thing at a time. And if you didn't finish it, you weren't going to finish it. Whereas now you can stop and start and, again, do things somewhat simultaneously. It's very clear that the young generation, they know how to navigate different types of media communication way better than the older generation. So whether it's an electronic medical record, emails, texts, anything, that they can navigate technology better than what you would consider the older generation, the boomers, and many of the Gen X faculty that we have. So if that's not really hard evidence. So if you need hard evidence that millennials might be smarter a generation, then there is some hard evidence. There's data of incoming orthopedic surgery residents from 2005. This was when I was in medical school, or kind of around the age when I was in medical school. And the mean step scores for people that were starting residency in 2005 was 230. They didn't even report their average step 2 scores. They didn't even report how many publications and presentations they had. And this is literally pulled from that 2005 data. 1/3 of incoming residents had no publications, had 0 publications, and 2/3 had at least 1. That's kind of how we defined the characteristics of an incoming orthopedic surgery resident. Now, 2020, 15 years later, and these numbers have only gone up in the last 2 years. Mean step scores almost 20 points greater or up to 20 or 30 points greater. Mean number of abstracts, presentations, and publications, 14.3, and only this number has gone up. And compare and contrast to 15 years before that, where 1/3 of the incoming orthopedic residents didn't even have any publications or research to speak of. So we've got some soft and some hard evidence that today's resident generation might be smarter. You can make an argument that they have more imagination. Some other things kind of pulled from the internet. Maybe they have less brand loyalty. They value access over ownership. But these are just some key features of how we would describe millennials and how they differ from Generation X and baby boomers. They're always on the go. They're disconnected, mobile, everything. And with that imagination and just kind of with the internet and that imagination has led to more creativity. So again, you can kind of make these arguments for the millennial generation. I think there's a flip side. What are some of the challenges of growing up in the age of the internet or the current technology? Well, like how it might be a strength, instant answers and unlimited content, I think could be a detriment. So that same Google search, how to perform ACL surgery, 20 million results from how to perform ACL surgery. So if you pick the right 1 or 2 references or sites, then your money. And if you pick the wrong ones, you will be way off. And I think that problem of knowing what's good content, what's the right answer is a big deal. And I think it's more prevalent the more essentially infinite content you have access to. When you only had 1 or 2 things you could draw upon for an answer, you could take it to the bank that it was probably vetted out and it was probably real, and that's not the case anymore. One other big thing about just the current generation is this idea of instant gratification. Like the world is now totally hinged on instant gratification. So things like streaming TV. When I was a kid, I liked watching Seinfeld. A lot of my friends did. I had to wait till Thursday at 9 p.m. and turn on NBC to watch Seinfeld, like a show that I liked. Like I had to wait and physically turn on the TV at that time to watch the show that I wanted to. Whereas it does not matter what you like now. You can watch anything. You hear about people streaming, like just binge watching shows. It's just at the on demand click of a button. You could watch whatever show you want whenever you want to. You could Amazon everything. When I had to buy running shoes. When I was little, I had to go to the Foot Locker. I don't even remember any other store that had shoes, try on the ones that they had on the shelf, hope that I could afford it, and like leave with the pair that I thought might work out. Whereas now, sitting down on the couch, click of a button, shop by brand, type, colors, reviews, anything. You just literally at the click of a button get what you want without too much physical hassle or mental hassle. Instant meals. When I was a kid, I ate a lot of ramen for better or worse. I had to boil the pot of water, like put it in the dish, clean up everything afterwards. And now, instant. Put hot water in there, eat it, throw everything away. There's literally no waiting. And just again, with the instant answers and the content, I pulled up all these images instantaneously when I put this talk together. So like that, you never could have done that 15, 20, 25 years ago. And so just like just instant gratification, instant satisfaction, instant satiation of everything. The lens of social media, I think, is a huge thing that we totally underestimate or underappreciate how much that affects how millennials and for certain Generation Z think, like how they process life. This idea of Instagram life, it's kind of like you only see the best versions of others. You only try to present the best version of yourself, and you only see what ultimately is the best version of someone else. You know, it's like the lens of social media, of what is real and what is presented, it can be so stark. This is the same human being that looks one way through their Instagram life or their social media life versus the reality. And I think you could take this example across the board. This is my kid last week who looks perfect and cute. And my family and my in-laws and friends all think that my youngest kid looks like this all the time, when he honestly, 90% of the time he looks like this. These pictures were actually taken the same day, and he looks like this way more often than he looks like this. But this is the picture that we text or email to our friends and family or post. And then again, moving that to an example of the into orthopedics, our trainees, like they remember they see the best of someone else, and they only kind of remember the worst of their own experience because it doesn't seem like it matches up to what the reference is of out the social media lens. And you know, it doesn't matter if we're operating side by side in the first case. Heck, they might be doing everything and I'm like just standing behind them the second case, but they'll kind of remember the third case where I elbowed them out of the way and they had to hold hook because, you know, it was going slow or not right. And so just kind of the lens with which people just process things, I think is altered, and social media is a part of that. And so again, you know, another challenge I think that hinges off one of the strengths of the millennial generation is that being, you know, in some ways more creative and having more imagination. I do think that there's some weaknesses where, you know, you can be driven by emotions versus logic, and you could think of things or solutions more in an aspirational way versus a practical way. So like what you want to get out of something or how you think something should be is more aspirational rather than practical, or kind of hinged on how you feel rather than what it makes sense. And I do think that is in part a byproduct of being more creative and having more imagination. Again, good and maybe some bad or challenges to it. And so when you contrast this new generation and maybe think about how we think of old school teaching or thought process, and these are just examples from my faculty that I hear at meetings or when we're talking about, you know, trainees or issues or things that I have experienced myself as a trainee, learning from what I would consider old school faculty. And an old school way of teaching is really hinged on teaching content. You know, didactics, like we needed the expert faculty to get the answer. Like they had the answers. We needed them to give us the answer. And that's very like rooted in kind of a traditional didactic style of teaching. And along with that was watch and learn. I can't remember how many times I got told that when I was a resident. Watch and learn. You will get better if you watch and learn. And this idea of graduated responsibility, you got to crawl before you could walk, before you could run. And all of this is rooted in delayed gratification. There's nothing instant about watching and learning, or this idea of graduated responsibility where over time you get better / do / hone your skills. And so again, just to compare and contrast the old school versus some new school thinking. And then, put your head down. Don't stay in your lane. Put your head down. And that is a very non-millennial concept, if you think about it, with social media. Like, we're actually encourage people to speak up, to share your feelings, to post everything about your life and comment or tweet or anything. And it's very, very, very opposite to kind of what I think the current or younger generation mentality is of how they think about to process life and go about their day-to-day. And so knowing that and knowing maybe the strengths and the challenges of the younger generation, and I think there's some ways to think about being a new school teacher in terms of adjusting with the times. So instead of thinking of yourself as the content provider, it's more about teaching concepts and philosophies, why you think what you think, or how did you figure out to know what you know or do what you do, rather than this is the answer I'm providing to you because I'm the content expert. And along those lines, giving direction and parameters versus rules. I think people, I don't know, maybe it's from this Montessori style of learning when they're kids, or there's not rules or specific tasks to do. But I do think that the newer learners do better when they're given objectives and given more parameters rather than specific, rules or lanes to stay in. And involving trainees in creating solutions. I've kind of gotten the most positive feedback when I just simply ask a trainee, how would they solve this problem, whether it's program related or for a patient or for another resident. I think that something gets stirred up in their mind that triggers these creative imaginations, or however they're wired. It triggers something. And I don't think this is actually unique or part and parcel for the millennials, but I think every generation and every person could do better if you focus on reasons why something will work rather than focusing on the reasons why something won't work. I think we have the human nature, we're built in a way that we try to figure out why something's not right or why something's not good to change, rather than thinking about why it might be good to change or how it might work, for the better. And so taking all of these into account, my focus at the University of Washington is just to try to remind faculty and residents that it's not an us versus them thing. There's not old school versus new school or faculty versus residents. We're kind of all in this together. And one thing to just know, that perception is as important as reality. We see examples of this as surgeons, where a patient's thinking that they're doing well after their surgery is more important than them actually doing well, however it is that we define. And so you could find examples of that all up and down medicine, but I think no greater example than when you're teaching residents. So, we want them to do better and improve, but it's almost as important for them to feel like they're getting better and improving. And that's the trick. That's the challenge. And along those lines, don't disregard how people feel. It's become more and more important about how people feel and what they perceive than what is actually happening, or how you perceive something is happening to someone else. But at the same token, don't let feelings drive decision making. Everything that we do is like rooted in reality and practicality, and so we have to be, stand firm in our beliefs when we think that that's what needs to be done, and we can't let perception or feelings of our trainees completely drive what we're trying to do or how we're trying to teach them. And then one thing that I try to do is remind our trainees and our med students and people that are looking to apply to our residency is that learning is a really active process. So a lot of the new generation, because of internet and social media and ease of everything, they think that once they plop down, that they can just learn, that they just can lean back and just learn, get their learn on, so to speak, by just passively existing. And we all know nothing could be further from the truth, that learning and getting better is a really active process that takes a lot of time and energy and intentionality. And that's a message that I keep trying to reiterate and reinforce with our trainees. And then lastly, and this is just a me thing, I don't know if it's a generational thing, but just trying to maintain the focus on others. When people are down, when they're depressed, when they're blue, it's mostly because you're just kind of shining the spotlight at yourself and like thinking about how your lot in life is not as good as you want it to be, or how you didn't get the reps you wanted, or how you didn't get treated how you wanted by somebody else. And when you could just take that spotlight and just turn it on anything else, especially another person, hopefully the patients that we are in charge of taking care of, that those feelings get better. And again, that's an exercise, like my own self-help thing that I've been trying to do, more of lately. So, again, that's, nothing really scientific about any of this stuff. And it's still a work in process of me just trying to understand how our current learners really will take to our teaching. But that's my take, as what I firmly believe to be from the Gen X era, and hopefully just kind of keep modifying what we do to teach orthopedics to this future workforce, that they're going to be the ones taking care of us when we're broken and having cancers and hip fractures and geriatric ACLs and stuff.
Those are three terrific lectures, and again, ended on a high note with the focus on the next generation. Speaking as a Generation O for old or Generation B for boomer person, one critical question for us was that sense of responsibility. I know I'm speaking like an old fogey, but how do you see that? We obviously did not have work hour restrictions. Nowadays, everything seems to be just shift work, and that ultra responsibility for a patient may or may not actually be frowned upon, because you got to keep your hours to a large degree. So how does that work for you? Is that sense of responsibility, that dedication towards patient care and putting in the extra hours, less developed in this new generation, or with this ADD and just kind of, hey, we can manage this digitally, or is that just a fear of an old person?
That's such a great question. I think that fear is rooted in some reality that we see in the younger generation, where I don't think the younger generation thinks of orthopedic surgery as their defining who they are. I think many younger orthopedic surgeons in training think of this as an awesome way to make a difference and have a profession and a life. But I do think that the starkest difference between the boomers and Generation Y and Z is that when you became an orthopedic surgeon back in the day, that was everything. That was who you are. That was that made up the whole of who you are. You kind of, your whole identity was being an orthopedic surgeon. And I personally don't know if I feel that way, and I for sure don't know if I feel that our residents feel that way about being an orthopedic surgeon. And so I don't know how to reconcile that.
Great point. And a simple question: are textbooks just dead? I mean, I know we had to read chapters with greatest dedication, and nowadays everything seems to just be little tidbits as much as it fits on a smartphone. So are textbooks just, should I clear out my bookshelves right here above me, or is everything now digital and ranked by algorithm?
Dead. I think they're dead.
Gone.
Yeah, and for three reasons. One is we just have digital subscriptions, so people just load up on their iPads or their desk or their laptops, Campbell's and Green's Hand and Delay and Dres, Sports. They just have the volumes loaded electronically. Number two, just that it's that idea that instant answers, where in the time that it takes to create, proofread, publish a book, that data is like 2 or 3 years old at best. And the generation now, they won't tolerate something that's like 3 minutes old, like info that's 3 minutes old. They won't tolerate that now. So I personally believe that the books as we know it, textbooks, it's over.
You've just given me years of my life, because all those invitations for textbooks, I can ditch those now. I can just tell them I'm done with that.
Yeah,
No,
well, they might be they'll be if they're a digital form, then and you get that info out really quick, then maybe you're onto something.
Great stuff. Thank you, UW. Thank you for all three of you for really providing very valuable perspectives. There'll be a very nice resource for our generation XYZ and the old fogies like myself. I know I had some texts from some of my colleagues who watched on Facebook, and they concur that it's so exciting to have such bright young minds take us a big step forward. And thank you, Dr. G, also for joining us there. And congrats to your work. And hopefully we'll see you next month when we talk about how to teach and implement osteoporosis to everyday care. I'd love to have your collective minds. Thank you all very much.